Succes i veterinær praksis, podcast nummer 135. Dagens podcast er relevant for dig, uanset hvilken ultralydsscanner du har adgang til i klinikken. Det kan for så vidt være sådan en lille håndholdt en, som står støvet ude på lageret et eller andet sted, som ingen rigtig sætter strøm til. Eller det kan være sådan en kæmpe stor en, som din chef har stående til at scanne hjerter på. Det er i princippet fuldstændig underordnet. Og selvfølgelig kan den store maskine meget mere, og der er mange flere knapper at blive forvirret af, men du skal kun bruge en 4-5 stykker, og det kommer vi ind på i dagens podcast. Du kan nemlig få nogle diagnostisk ret vigtige detaljer ud af dine patienter, hvis du ved præcis, hvad du skal kigge efter, og det er det, vi skal grave os ned i dag. Og så synes jeg, det er lidt sjovt, at ham, jeg skal snakke med, han har det samme navn som mig. Vi starter selvfølgelig lige med at snakke om det, for han bor ikke i Danmark og kommer for så vidt ikke fra Danmark, andet end at han har noget dansk baggrund. Og det er jo selvfølgelig mest sjovt for ham og mig, altså, men det har altid været lidt en udfordring, det der med e-mailadresser og sådan noget, at have et ø inde midt i der, og det er jeg jo så lidt interesseret i, hvordan man så kan leve og bo i et engelsktalende land med sådan et bogstav. Men det tager vi lige at starte med, og så graver vi os ned i det faglige indhold, og der er meget at komme efter, særligt hvis ikke du er vant til at bruge en ultralydsscanner. Det kræver nemlig ikke en hel masse erfaring og en hel masse særligt udstyr, som sagt. Der er links og noter og nogle billeder fra dagens episode. Det ligger som sædvanligt over på hjemmesiden under episodens nummer, og det her er som sagt nummer 135, så dem finder du på SIVP.dk/135. Husk også, at du kan få adgang til de online kurser, der ligger over på hjemmesiden. Du kan få 4 ugers gratis adgang som podcastlytter. Så kan du kigge indenfor og se, om det er noget for dig, og melde dig fra igen, hvis det viser sig ikke at være. De 4 ugers gratis adgang får du på SIVP.dk/4 uger. Og så over til dagens interview med Søren. Hi Søren, and welcome to the podcast.
Hello, thank you very much for inviting me.
So before we begin, I will of course have to talk about your name, because this is, to me at least, a bit unusual. So I found you online and saw a guy, a vet, even with a name like mine, and I just reached out, and of course I wrote you in Danish because I just assumed that that you were Danish because of your name. You have the same as me. So, and even with the Danish letter in it. But can you please tell us why and how that is working for you?
Absolutely. So my dad was born just outside Copenhagen. So my dad is Danish, and he came over to Canada in his 20s. And he met my mom there, who's from England. And they had 2 kids, me being one, and I have an older brother. My older brother got the English name, so he's Richard. And my dad is Sven, so his name is Søren Boysen. And being of Danish descent, I got the Danish name. So I have the same name as yourself, and it has been a lot of fun having a different name. It makes me very unique within Canada, because I have yet to come across someone with the same name as myself within Canada. It does make it challenging, and I often end up getting called just about everything you can imagine, from Sean to Sam to anything else with my name. But I am very proud of the Danish heritage. I still have relatives, cousins, uncles, and aunts in Denmark, and I do try to get back to Denmark at least every other year, or as often as I can.
Yeah, and you were here last year, as you told me just before we started recording.
Yes, I was actually fortunate enough to be invited over to the University of Copenhagen and the veterinary college there, where they asked me to come in and do some point-of-care ultrasound training for their interns and some of the faculty. And I had a fantastic time. Like I said, I always love going back to Denmark, and any excuse that I have or I can find to go back to Denmark, I will definitely take that opportunity for sure.
So what else is important that the people know about you before we start on today's topic?
Well, I guess I could just give a little bit of background about myself. So I did graduate from the Western College of Veterinary Medicine in Saskatoon, Saskatchewan in Canada. Following that, I did do some time in private practice on the west coast of Canada, British Columbia, just outside of Vancouver. I then did an internship on the east coast of Canada at the Atlantic Veterinary College in PEI, Prince Edward Island. Following that, I went down to the States and I practiced in Chicago for a year, and then decided I really did want to delve more into emergency and critical care. So I went down to Tufts in the United States and did a residency in emergency critical care. Following that, I came back to Quebec and did some teaching at the University of Montreal in French. And then when they opened the University of Calgary, which is the newest veterinary school, we have 5 veterinary schools in Canada, and Calgary was the most recent one. It opened in 2009. We graduated our first class in 2012. When that opened up, I jumped at the opportunity to come back closer to Western Canada, where I was born and raised. And that's where I am now. I've been here for 11 years, and I am a professor at the University of Calgary in the Faculty of Veterinary Medicine, specializing in small animal emergency and critical care. But anything critical, whether it's a dog, a cat, a horse, a cow, an exotic animal, wildlife, if it's critical or it's an emergency, I am definitely going to get involved with it for sure, because I really do love what I'm doing.
Good. So I think we should keep to smaller pets, dogs and cats mostly. That is the main focus of this podcast anyways. And of course this today's topic is a bit visual, of course, but I hope we managed to get around, and there's of course some theory as well. And most people listening to this podcast will be in some sort of GP. They might not be referral vets that take in cases to ultrasound, but most vets have at least a small ultrasound machine that they try to use from time to time to get to make sense of. So hopefully you can give us some tricks and maybe help us get more out of the machine anyways, more information out of the machine.
Yes, and I'm going to say, to me, that's perfect. And that's exactly what we try to do with our point of care ultrasound, our approach, because I was never formally trained in ultrasound. And when I actually started my residency in emergency critical care, my first thought was, because I tried using ultrasound, it kind of sat in the corner and I would go do a cystocentesis with ultrasound. And that was kind of the limit of my skill. Maybe if I felt brave, I would look for pericardial fusion, but that was it. And I had no misconceptions that although I loved the idea of ultrasound, I was not able to do it. When I started my residency, I got super excited and said, this is fantastic. I will now get to learn ultrasound. But when I started, my mentors, John Rush, said to me, you will not get to do point of care ultrasound, or you won't get to do any ultrasound. It's only the radiologists and cardiologists that get to do ultrasound in their residencies. And I was very disappointed with that. But then he actually said, unless, and that to me was the key or the caveat, unless you can do a research project. And I thought, oh, okay, fantastic. I really want to learn ultrasound. So I went and read the human literature. And the first paper I found was a point of care ultrasound called the FAST exam in humans suffering trauma that just looked for free fluid at 4 sites in the abdomen in under 5 minutes, and it was as sensitive and specific as CT or diagnostic peritoneal lavage. And I thought, okay, this is something that anybody could do. And that's where it all started, where the FAST exam started, and that was back in 1999 that we did that. And we developed it from there and found that it is something that you can do in less than 5 minutes. You can do it with minimal training, and it takes you a step now beyond simple looking for the bladder like I'd started with. And it allows you to apply that every day in a number of our different patients. They could come in with the painful abdomen. They could come in with trauma. They could do poorly after surgery. And I'll always pick up the ultrasound probe and start to evaluate those patients with point of care ultrasound. And it's done very rapidly, and it takes very minimal skill. What we actually do on a daily basis in general practice with almost any machine that I can get my hands on, doesn't have to be one of those big expensive ones. Could be any machine, and I'm scanning for free fluid in the abdomen. And then what we found was once we'd sort of taken on the abdominal point of care ultrasound and the simple things that we could do with that, we realized on the human side they were now looking into the thorax. So we also, even back in 2000 and 2001, started evaluating and playing with the pleural space in the lungs and some of the other things we could look at very quickly and rapidly with minimal skill or training and apply every day in daily practice. So we basically, when we do our courses or our hands-on training, we take people that often have never picked up an ultrasound probe before, and by the time they're done with even the 4-hour session of ultrasound hands-on training, they are confident then applying that, because we have a very practical approach in how we apply our ultrasound. We're asking binary questions, essentially, or very limited clinical questions based on how that patient presents, that anybody could easily do. So, does he have free abdominal fluid? Yes or no? Does my patient have wet lungs? Yes or no? That's something we can easily look for with ultrasound as soon as you put it on the chest. As long as you know what you're looking at, it's incredibly easy to do and super applicable, super easy to do by any general practitioner. So it's really exciting. And I guarantee anybody that's listening that has an ultrasound machine that's wondering, is this something you can do? The answer is 100% yes. I absolutely guarantee it. We teach our students to do this in third year, having never picked up an ultrasound probe before. And by fourth year, after this lab and some simple lectures, they're doing it in their fourth year clinical rotations.
Wow. So I've never heard of this before. So before I read your article on it. So there's definitely going to be someone out there like me that doesn't know what this is. So we need to unpack it a little bit. You call it a fast scan. Is that because it's quick and everybody can do it? I mean, if I take the ultrasound probe, I just wave it around, and sometimes I'm lucky find a kidney, and sometimes I see the caudal pole of the spleen, and then of course I can find the bladder, and if it has a pyometer, I'm definitely going to see that. But that's about it, right? So you're actually telling me that you can teach me within under 4 hours to say yes or no if there's fluid in the abdomen.
Absolutely. I'm going to say that with confidence because we've done the research on it with students. So it is called the FAST exam, and that has actually a double entendre to it, because the FAST is because it's done in less than 5 minutes in the trauma settings. We can expand that a little bit and get it up to about 7 minutes, but most of the time, if we're just looking for free fluid, it's less than 5 minutes. So it is fast, but the FAST also comes from the fact when we first applied it, the FAST is an acronym that stands for Focused Assessment of Sonography for Triage or Trauma. So when a patient comes in unstable, if you look at the odds, we did this research as well, if you look at the odds of a patient comes in that's unstable, say it's cardiovascular unstable or it has respiratory distress, and we classify it as unstable on the emergency setting, we did a study to show that if you put a probe on and you scan in less than 10 minutes the chest and the abdomen, you have a 75% chance or higher, whether it's a dog or a cat, and this is just unstable, no trauma cases here, just unstable, 75% chance or higher that you will find something with your ultrasound that helps direct where you're going to go next. And we set that study up with a fourth-year veterinary student. Just again, to emphasize, you don't have to be a boarded radiologist or a specialist to be able to do point-of-care ultrasound or FAST exams. So that's exactly what we did, was sat with a student on the emergency and had them scan patients that came in. And like I said, whether it was a cat or a dog, if it had respiratory distress or was cardiovascular unstable, so the heart rate was elevated in our dogs or elevated or low in our cats, 75% chance or higher that you could find something. And most of the time, what are we looking for? Fluid, whether it's in the pleural space, the pericardial space, or the abdomen. Now, we have gone beyond that, and I can tell you if you've got water in the lungs, you've got edema, then that's incredibly easy to pick up as well. And what we do to make sure, like you said, you just put it on and hope you find something, we have very structured sites that you want to look at. So when we do our labs, for example, we'll show people how to trace the ribs up to the subxiphoid and then place the probe at the subxiphoid and tuck it under that area. So you get a good look at the pleural space, the pericardial space, the liver, the gallbladder, and the sections between those when you're scanning that specific spot called the subxiphoid site. And then we have the two paralumbar sites where we do show people how to easily identify the kidney by tracing the ribs caudally until you hit the sublumbar muscles. And right there where your finger pops out, that's where you're going to find the the kidney on the left side, and usually it's in the similar spot, but just tucked underneath the rib cage on the right side. And then, of course, the urinary bladder, as you said, you've already found. Everybody's comfortable with that. But that's actually, if you talk to specialists or look at the research, one of the most sensitive spots you can pick up free fluid is the apex of the urinary bladder, right at the most cranial aspect. So it's, again, we standardize the sites you look at so that when people pick this up, they're not just randomly putting the probe anywhere on the patient. They're asking a specific question. In this patient, do I have free fluid, yes or no? And looking at the specific sites that have been shown to document or find that fluid with an incredibly high sensitivity and specificity. So all of the questions we answer are very simple clinical questions, but there's probably, if I had to guess right now, I'd say there's probably about 12 to 14 questions that we teach that people can easily look for and answer. And then if you think about all the different clinical settings, whether it's an emergency or if it's just general daily practice where you might ask that specific question in that patient, then you can pick up a probe, and I guarantee you this is something you can do. Our success rate, like I said, with students, we have people that switch from large animal that come over to small animal and have never really picked up any other kind of probe besides a rectal ultrasound probe, that we have them doing this. And then they send us clips and they send us emails and messages all the time. And we actually just did a course with the crew in Australia online where we did some virtual telemedicine training, and they were sending us pictures of the cases they'd seen that had aspiration pneumonia that they could diagnose with ultrasound and didn't have to take off to the x-ray suite and get radiographs in. So absolutely, I'm going to tell you that this is something I pretty much guarantee you will be able to do if you pick up a probe and you get a little bit of training in it. It doesn't take much. It takes very little training to do it.
So this comforts me a little bit. So you and there is some graphics in your article about this. So it might be difficult to remember the sites just from hearing them, but there is some very nice schematics in your articles to go look at, and that is pretty easy. So if you know and can remember where to put the probe, it's fairly simple.
Absolutely, and like I said, once we've taken the course with people, especially the abdomen, most people, like you've already said, are used to looking for the bladder, the urinary bladder, are used to looking for the kidney and maybe the spleen. So we're taking sites that most people are already familiar with and just standardizing it when we look for fluid to make sure we get those 4 sites. And find that the success rates for people, once you organize their thought process and say, here's how you should look for fluid in the abdomen, under 5 minutes at these 5 sites where you're going to have a sensitivity and specificity of over 90% to find it, people then get very comfortable putting the probe on and looking at those sites. So again, rather than say, well, I don't know, I guess I could pick up a probe and hope I find something, and we say that's probably not the best way to go. Think about what you want to look for and apply
it. So how is that? So there's these specific sites, but how is it done? Is the patient in lateral recumbency, or is it lying on the chest? Can you have it sedated, or do they need to be awake? Or, how is this set up?
Yeah, so that's a really great question as well. And what we do is, it depends a little bit on how they present. So if the animal's comfortable and he's not unstable, and we still want to look at the abdomen, for example, in a patient that's been struck by a motor vehicle but is relatively stable and it's comfortable to lay in lateral recumbency, then we might lay it in lateral recumbency. But what I will say is, especially if our patients come in with respiratory distress, we don't want to cause them any undue stress by restraining them. So that's why, again, I find it hugely advantageous to do point-of-care ultrasound over radiographs. Because if you take a cat that's dysmic, for example, and you try to get a radiograph and you restrain that cat, he could turn blue and he could, with the work of breathing, go into respiratory arrest. Whereas with point-of-care ultrasound, the way we approach it is, and we've got multiple videos. So if you can put a stethoscope on the chest in a dysmic patient, you can put an ultrasound probe on your patient with no more stress. So when it comes back then to your question, what position should they be in? If they're in respiratory distress, I scan them in the position they are most comfortable in. So if that patient's doing everything he can to breathe, I let him keep breathing. I give him some oxygen. I give him an anxiolytic to decrease the work of breathing. And when I feel that he's comfortable, just as I would listen and auscult that patient for underlying problems in the chest, I put the probe on that patient. There's no more stress of doing an ultrasound than there is of listening. and I don't do any more restraint or try to change their position any more than I would when I listen with a stethoscope. So I think of the two as being interchangeable when it comes to point-of-care ultrasound. So I encourage everybody to get comfortable scanning them in the position the patient's most comfortable. If he's really stable, then I might put him into lateral recumbency just for the sake of having good access to the different sites. But I do all of my evaluations of the abdomen, of the thorax, including the pleural space in the lung, and even the heart I'll look at with them in standing positions or sternal positions. The one thing I never do is if they're unstable from a respiratory or cardiovascular standpoint is put them on their backs. Because if you've ever gone to surgery and you've been feeling a pulse or you've got a Doppler blood pressure on the patient and you put them on their back, the weight of the abdominal organs compresses the vena cava, decreases venous return, and you can actually hear the fall in the Doppler pulse when you have a Doppler on. So you can cause a unstable patient to decompensate if you put them on their backs. And because we're doing this often in the emergency, I just tell people not to put them on their backs when they're doing point-of-care ultrasound, even though many radiologists and many people that do ultrasound are trained to put animals in a V-trough, in a cushion, and scan them when they're on their backs. We do everything in standing, sternal, or lateral if their patient's comfortable enough to do that. And when you think about it from the standpoint of why we started doing all this point-of-care ultrasound, most of the time it is in trauma or unstable patients. They might have back fractures or limb fractures again, or if they're respiratory distressed. I don't want to compromise my patient. I'm going to scan it in a position they're most comfortable.
Mm-hmm. So again, that simplifies things a bit, because sometimes tipping them around and having two nurses or technicians to help you hold the animal down, and that is also a challenge. So like I would listen to the animal with the stethoscope, and using the ultrasound the same way is way simpler.
Absolutely, and you hit that perfect. That was an awesome summary. Exactly the same. If you can listen to it, you can ultrasound it. And I do this with them in the oxygen cage. If I get a patient that's really in respiratory distress, I give them a dose of anxiolytic, often butorphanol, for example, or something else to just calm them down, decrease their work of breathing, put them in oxygen. And when they're breathing a bit better, just like I would reach in and listen to it while it's in the oxygen cage or incubator, I put my ultrasound probe, I bring the machine to the oxygen cage, I reach in and I scan that patient in the oxygen cage with the minimal stress that I can. And I can get 90% of the time all the answers I want with regards to, is there something in the abdomen, something in the pleural space, something in the lungs, or something in the heart? And those are the big areas we go after. We go after the abdomen. So we got abdominal point-of-care ultrasound. We go after the cardiovascular point-of-care ultrasound, so the heart and some of the bigger vessels. And we go after the pleural space in the lung. So those are the four big areas that we currently concentrate on and focus most of our clinical questions, and that rapid 5-minute clinical, do we have fluid, yes or no? Do we have edema in the lungs, yes or no? Those are the things that we really focus our attention to when we're doing our point-of-care ultrasound, those four big organ systems.
So, but you have to clip them first, right? You have to get direct contact to the skin.
Another great question, and I'll say when it comes to point-of-care ultrasound, I never shave my patients. If you have an older machine, or you've got a dog, for example, with a really thick undercoat, so some of those northern breeds like the Huskies, then occasionally we may shave a small section, but I would say that 95 to 99% of the time, I will just part the fur, apply alcohol to the skin, and apply the probe to the parted fur where I can see the skin, and I'll get a great image. I can add a little bit of gel if I want, but make sure if you use gel and don't clip, that you smooth it out, because the hair the fur can trap the air when you use gel. So I would say that, if you ever see any of our lectures, or you see any of our podcasts online, all of the images that you'll see us using are obtained with alcohol and separation of the fur. We don't do any shaving. And same thing in our labs, when we do our training labs, to make it as real as we can, all of our ultrasound labs are done without shaving, just using alcohol and parting the fur. So that's another big difference. And the only time I would be really worried about that, most people don't have to worry about defibrillation, because obviously if we have alcohol and you defibrillate a patient that goes into arrest, they could catch fire. I have unfortunately seen it a couple of times. It can happen. But most general practitioners don't have defibrillators for CPR, so it's not an issue. But some general practitioners will have laser cautery. So again, then you do have to be a little careful if you're thinking you might take a lump or do a small surgical procedure on a patient. You have to consider whether alcohol might be a risk for catching on fire.
Yeah, I've done that with the electrosurgery as well. So,
yeah.
Well,
yes,
it's
something,
fairly
something you need to be aware of.
Yeah, and it's not easy to explain to the owner, but that's yeah. Well, that's a story for another day. So. But that might be the reason why I find it so difficult to get good images, because I just drown my patients in gel. So maybe I should try with that next time.
Yeah, so like I said, I think it's something to try, and if we're having difficulty, then I might shave them. But I would say, like I said, 95 to 99% of the time, we just use alcohol and part the fur, and we get great images. And if you look at any of the podcasts or any of our sessions online somewhere, there's a few out there that are open access. We just did the ISFM conference for the feline medicine group, and we did a series of point-of-care ultrasound lectures for them. We did EVEX, the European Veterinary Emergency Care Society, online, and there's some images in there. We just did IVEX this past weekend, actually, down in St. Louis, all virtually because of, unfortunately, the COVID situation. Mm-hmm. But all of the images you see in all of those lectures and all those ultrasound clips that are in those talks are all done using alcohol and not shaving. And same thing with the podcast. If anybody goes on to the University of Calgary Veterinary Medicine website, the UCVM website, we have some podcasts there that are open access. Just type in UCVM podcast and you should come to our site, and you'll see the images in those clips as well are all without shaving and just using alcohol.
Perfect. And I will, of course, make sure to put links in the show notes for all the places mentioned here. So for people running on treadmills and driving cars, they don't have to fall off to write everything.
Very
down.
Good point.
Yeah. So, Søren, how about the machine itself and the probe? What are your recommendations for the technicalities?
Yes, and I'm going to say that for equipment. When I started out, we took the equipment. So when we started out, when we did the first study at Tufts, that was, like I said, back in 1999. And the machine we used then, which was perfectly adequate, is not going to be even available. You couldn't even find it if you tried now, because it was already obsolete when we started that study, because the radiology service had abandoned it 7 or 8 years earlier. So any machine can be used for point-of-care ultrasound. And a lot of people though do ask, what machine do you prefer? And I'm going to say, if you buy anything that's probably within the last 5 years, the technical advances towards the ultrasound equipment and machines is tremendous. And we honestly need the minimum, the absolute minimum in those advancements to do the type of ultrasound we're doing. If you want to buy a really fancy machine and eventually get into more advanced ultrasound, like measuring shortenal fractioning and wall thickness in the heart, and get into specific pancreatic changes that you can look for with more skill, then a higher end machine's great. But when it comes to point of care ultrasound, any machine that you can apply to an animal is going to be sufficient, because our types of questions we're answering don't require expensive machines. And if you actually look at some of the human literature, one of the biggest names on the human side is Daniel Lichtenstein, and he recommends using an older, lower quality machine because you can look for artifacts specifically in the lung that are easier to pick up with the older technology than with the newer technology. So he actually recommends one of the older machines over the new ones. Now, for all the stuff we do, I would honestly, the only thing I would say is you need to make sure you've got a microconvex ultrasound probe. So you've got 3 different probes you can use for ultrasound: the linear array, the phased array, and the microconvex. The phased array is usually used for motion, such as detection of problems in the heart. I never use a phased array probe. We don't have one on our portable ultrasound machine, so I never use a phased array. Do I look at the heart? Absolutely I do, but I always use the microconvex probe. And I use that actually for everything. I use it for the heart, I use it for the pericardial space, I use it for the lungs, I use it for the pleural space, and I use it for all of the abdomen. So if you had to pick one
sorry
probe,
for interrupting, but that's the small pointy one, right?
Yep, that's the small one with a little curve to it. And that's your workhorse probe. You can do every single thing that we teach using just that probe and that probe alone. If I was going to say what other probe, if I had to pick a second probe, in addition to that small one that has the little curved head on it, then the next probe I would choose would be the linear, the long flat one that's got the flat surface. That would be my second choice, because we do teach technicians and we do teach general practitioners how to use your ultrasound to place an IV catheter or get a blood sample when you have a difficult patient that you're having trouble getting a catheter into because of edema or hematomas or just really thick skin. Then we do train people how to place catheters with ultrasound guidance. It sounds complicated, but it's incredibly easy. And again, we teach our students to do this, and we've developed a really neat model to train technicians and veterinarians or students, and that's using a raw chicken breast and some plastic wrap. And you can make a great model with that and a balloon. You fill a balloon, like one of those long, thin balloons you use to make animals with. You fill it with water, put it between two chicken breasts, wrap it in plastic, and you can use that as a vessel. And if anybody's interested, they can send me, again, an email. If you want to make my email available at the end and provide that. I've got videos and I've got pictures, and I'm more than happy to share with people how you can create the chicken phantom model. And I've got a video of us showing how you would use that to place an IV catheter or draw a blood sample from a patient that you might be struggling to get that from, because it's super easy to do. It sounds complicated, but it's easy. And that's why I would recommend, and the only reason I would recommend the linear probe, the long flat one, is if you get more into the vascular stuff. I can still, and I do show people, if they don't have a linear and they come to our lab, I tell them they have to put their catheters in when they practice the lab with us using the probe they have in their practice. But if you're going to get a second probe, the linear is probably my second choice, because it works well for vascular structures. And sometimes in cats, smaller animals, if we're scanning ferrets or we're scanning cats, we can use a linear to get a really nice detail on the kidney, for example, as well. So that would be my second choice. And then the phased array, like I said, if you are going to get into hearts and you're going to try to specialize, then that's a nice probe to have for that reason. But I'll say that it's really rare that I ever use a phased array probe. And I almost always use the small little pointy one, the microconvex probe. Usually between 5 and 10 megahertz is the frequency. If you're looking for a probe with a specific range on it of frequencies, the microconvex, the small one with the curved head, between 5 and 10 megahertz, or even 5 and 7.5 megahertz, if you don't have as much range on your probe, is what you'll need. And you can do every single scan that we've ever taught or ever shown using just that probe. And some of the newer machines, if you guys are just breaking into ultrasound and you're wondering, well, what about the portable machines? What about the true small ones that you can carry? So there are some newer ones out there. And there's lots of them out there. The Clarius is one example. The Butterfly is another example. GE has one that's very small and compact. And the resolution on those is not as good as the true portable bigger units. But when, again, it comes to point-of-care ultrasound, we can get the answers we're looking for with any of the machines that are out there, whether they're the smaller Butterflies, the Clarius, or you're getting into Eosete, the GEs, the Sonocytes. All of those machines will answer the questions that we want. And if you're just breaking into it, anyone will work. If you're trying to grow into ultrasound and become more specialized, generally, then it might be nicer to pick up one of the higher end units so that you could expand into that. But starting out, just grab any machine and a microconvex probe and you are good to go.
Mm-hmm. So, and the one we have where I work is I don't even know the brand name, but it's a laptop thingy, and with the exact 2 probes you mentioned here as well. And we get fairly good images from my judgment anyway.
Yeah, and that's perfect. The fact that you said it's a laptop, and that to me is also really nice. If you gave me a choice between one of the big consoles and the laptop styles, the laptops are nice and my preference because I could take them anywhere in the clinic. And that's one of the things we really emphasize as well. If our patient's not stable, bring the machine to the patient. Don't bring the patient to the machine. So you bring the machine to where you're giving oxygen, you're putting IV catheter in, you might be doing fluid resuscitation, and you bring the machine to the patient and you scan it while you're keeping that patient as stable and comfortable as possible. If your patient's really stable, then absolutely you can bring it to the machine. But I would honestly again say, if you've got a smaller machine that's mobile, like the one you just mentioned, that's the ideal for us, because we take it to the cage, we take it to the ER, we take it wherever that patient is, and we need to get a rapid answer to figure out an underlying cause to direct our next diagnostic or therapeutic intervention based on what we find with our ultrasound.
So when you open up the machine, there's a lot of buttons. And of course, we don't have to press all of them, but can you maybe give us some of the most important ones that we need to know about to do this kind of scans?
Absolutely. And that's the nice thing about the point-of-care ultrasound that we do. I don't know all the buttons on all the different machines that are out there. I only really focus on 4 buttons when it comes to point-of-care ultrasound. The first one that's probably our most important is going to be the depth. So we do want to make sure that we know how to control how deep we look into the different organs or body cavities. So for example, if we're looking at the lung, if you think about where the lung's positioned relative to the outside of the animal, you're going through the skin, the muscles, and then you hit the intercostal muscles and the lung surface. Not unless you're really, really obese, and your dog or cat is only going to be in about 2 centimeters from the skin surface to the lung surface. So we usually scan the lung at a depth of about 4 to 6 centimeters. As opposed to the abdomen in a dog, we might go out to 13 centimeters if we're looking at the liver and that subxiphoid site. So that depth is really, really important for us to control, to make sure we're looking and optimizing the image when we're searching for specific structures or evaluating specific structures. So the depth is probably the first one to be really familiar with. The second is going to be your gain, so that you can actually change how bright or dark your image looks. And a lot of people say, well, what's the perfect gain when you're looking at the liver or the lung or whatever it is? And I always tell people it's like looking at art. Whatever looks pretty to you is how you should set the gain. So there's no exact specific gain. You play with it. If you go too far one way, things look really bright. If you give too much gain, it's like looking at the sun. It's just too bright and you can't see anything because everything gets white. If you make it too little gain, then it's like midnight and it's everything black and you can't see anything. So you pick something in between, but the exact fine setting and in between, even if you take myself and another colleague I work with here on a pretty regular basis, Dr. Serge Chaloub, we do a lot of our conferences together. He has a slight difference in how he prefers to have his final gain settings than I do. Overall, we play with it to get an image that's similar, but then I tweak that gain up or down a little bit so that I see what I want to look for in that image with the greatest degree of clarity. And that's a little different than Dr. Chaloub. So final adjustments, like I said, that's how you would perceive, make it look pretty. As long as you can see everything and it looks pretty, that's how I would adjust the gain and how I recommend to others to adjust the gain. After that, the other buttons that become somewhat important, if you have the option to change the frequency, then that's something else that is nice on some of the machines, because you can go from, for example, a 5 frequency to a 10 megahertz frequency. And the general rule of thumb is the higher the frequency, the better the resolution, but the poorer the penetration into the tissue. So if you're looking for superficial structures, then that 10 megahertz frequency is nice. So if you're looking for kidneys in a cat, for example, that's usually going to be around 7.5 to 10 megahertz frequency, in addition to the depth and gain that you play with. If you're looking deep into the abdomen, then we'll want the lower frequencies. So example, a Great Dane that you're scanning will want to be down at 5 megahertz. We don't get as nice a resolution, but we get to look deeper into the abdomen. So the frequency is not vital, but it is the third one that I tell people to become familiar with. And then the last one, there's maybe 2 there, the freeze button is really important. And this becomes important because you're scanning on the point of care and we're doing our emergency ultrasound. Our patients aren't perfectly restrained. They're not under anesthesia. We might give them a sedative to control their anxiety or a pain medication if they come in with trauma, but that's it for sedation. And if they are moving, but you get the perfect image and that patient suddenly moves. Let's say, for example, you're trying to get the heart or you're trying to assess the kidney and you're looking at that with some degree of detail and the animal suddenly moves. The freeze button is your best friend because you rapidly put out your hand, you hit freeze, and then most of the machines have a means by which you can scroll back through the sign loop that's there. And that to me is a key feature as well that people should become familiar with. Freeze and track. So you can move back slowly to where you were and say, yes, that was the kidney and there is fluid there. I don't need to upset my patient again by putting the probe back on. I can see that because I froze and scrolled back. So that's
you can go back 3 seconds or 4 seconds in time just from a freeze image.
Absolutely. And it varies a little bit. You can set that differently with the machines. And some of them, the newer ones, will let you go back 6 to 10 seconds. So it's truly amazing what that can do for you. Again, you just need to play with your machines and know what ability you have. But 3 seconds is usually enough. If you think about it and you're like, oh, there it is, 1001, 2002, 3003. That's more than enough time after you've said, there's what I needed, to reach out, hit the freeze, and just roll backwards. So it is a key feature than the freeze and scroll. And then the last one sometimes we'll play with is the focus. And not all machines have that, but when you set your depth, sometimes you'll have a focus button that will concentrate the beams of the ultrasound to a specific point in the window you're looking at to make it look a little bit clearer. But it's not vital, it's not critical. Depth, gain, freeze, and the trackball. Those are the big ones I tell everybody you should get familiar with. And I can do, again, everything I need to do with just those buttons alone. So I don't need to get into the frequencies if I don't have to. I don't need to get into all of the other focal point positions I can change. And then when it comes to some of the artifact things you can change in the machine, all the machines have different terminology. They have different patents for it. I have no idea what they're talking about most of the time. So those are the ones I go with.
Okay, perfect. Thank you for that. So I have one more question or one more topic I'd like to ask you before we end here. But this maybe is going to take us a bit away from the ultrasound in itself. But you keep talking about these questions that you ask, and we can answer specific questions. And that sometimes comes up in these podcast episodes that are more into medicine and internal medicine, blood samples and lab work, is that you would need a specific question that you would like answered. And what I tend to do, or used to do more earlier in my career, is I was just waving around with the ultrasound to see if I could find anything, and I would just take a blood sample to see if there was anything, or I wasn't quite sure what was inside the dog, so I just took a radiograph without having a specific questions, and that is something that is mentioned from every expert actually I've talked to about internal medicine. So can you, Søren, maybe talk to us a bit about these questions? What is it that you ask, and how far-reaching are the answers? What can we expect to learn from doing this kind of scans?
Yeah, that was a really nice summary you did. That was beautifully presented, and we take the same approach when it comes to point-of-care ultrasound. So it's not a standalone test that you would just apply and hope you find an answer to. It's used in conjunction with all your other clinical findings. So your patient comes in, you're going to get your presenting plate. You might do a triage examination and get a very brief history from the owner if your patient's unstable. And that information is usually going to direct where you go, because your ultrasound's complementary to those other diagnostics, history, and triage findings that you have at that point in time for that specific patient. So, for example, if a dog comes in and he's had a history of vomiting and now he's got respiratory distress, and I can see that, and I know he's got a history of vomiting, and I know he's got difficulty breathing, and I may have listened to him already as well, and he's got some crackles, I don't start by randomly putting the probe on the abdomen. That piece of information for that specific patient says to me, this patient's in respiratory distress with the history of vomiting. I'm worried about aspiration pneumonia. So then I'm going to ask the question, do I have evidence of B lines, fluid in the lungs? And do I have evidence of consolidation in the lungs? Yes or no? So I'll make it a very specific clinical question. In this patient with vomiting and respiratory distress, do I have aspiration pneumonia? And what do I need to look for? B lines and consolidation. Do I have either of those? Yes. Are they cranial ventrally? Yes. This patient, until proven otherwise, has aspiration pneumonia. Same situation, take another dog that comes in with respiratory distress, and that patient has a history of murmur, and you're worried that he's had a long-standing mitral regurgitation, and now he comes in with respiratory distress. That clinical questions based on that history and that presentation that I want to answer as quickly as possible in my unstable patient is, does he have edema in the lungs? Yes or no? Therefore, I put the probe on. Are there B lines increased in numbers? Which it's kind of hard to explain over a podcast what B lines are, but that's what we look for when we look for edema. And I can train anybody to do that. Does this patient have B lines, which indicate pulmonary edema? Yes. Is the left atrium enlarged? Yes. Then I'm going to go ahead and start treatment for that. So those are the specific types of questions you would ask. Or, for example, a dog comes in and he's had a history of eating things that he shouldn't. And he comes in and he's in shock. He's got low blood pressure. He's had a history of vomiting. I'm worried that he's septic. Does this patient have a septic abdomen? Yes or no? I look for fluid. I tap it. I know exactly where I'm going. So again, before I even put the probe on, based on the history, the triage, and the other clinical diagnostic tests that I have at my fingertips, as a global assessment of that patient, I know what question I want to ask and answer, and I can apply that very rapidly to that patient. So that's sort of how we would take the ultrasound as a complement to the physical examination in combination with the other clinical findings, and I answer a specifically clinically relevant question, and it's tailored to that individual patient based on the other information I have at that point in time. And that's the nice thing about point-of-care ultrasound. The person that has the probe in their hand with the patient in front of them is the best person to apply and answer that question with ultrasound. Now, are there things that I might miss? You bet, because I'm not a board-certified radiologist. I can't do everything that a cardiologist or a radiologist can do, not by a long shot, but I can answer a lot of very relevant questions. And even saying this patient does not have abdominal fluid is a clinically important thing for me to answer and might put me in a different direction in terms of what other diagnostic tests I need to do. So I always tell people to have a clinically relevant question they're trying to answer in their head when they apply ultrasound to their patients with point-of-care ultrasound.
So how about the patient where the vet answers, I don't know. I had a patient just last week that was a 6-year-old Lhasa Apso. I don't know if that's the correct English.
Yep, absolutely. Perfect.
And it was fine just a couple of hours before, and then suddenly it was panting and seemed to be in pain, and it was standing stiff on all 4 legs, and trying to feel the abdomen was not going to do any good. It was very tight. I couldn't feel anything. Heart and lungs sounded fine. So aside from panting and a very tense abdomen, I didn't really know what kind of question to answer to ask for, other than is there something in there?
Yes, and now that's a really good point, and that brings us back then to sort of when and how do we apply point-of-care ultrasound? And really, I think of it as 4 different points in which we can apply it. We can use it for triage, which is sort of what we've been talking about mostly up to this point, is those unstable patients where we got to get a rapid answer to a specific question based on how that patient presents. So that's sort of the triage approach. So we use it for triage. We use it for treatment. So if we find fluid, we can use ultrasound guidance to tap that. So it's treatment, it's triage, it's tracking or monitoring. So let's say, for example, again, I find a patient that has congestive heart failure and he's got increased fluid in the lungs that I see with ultrasound. I can follow that over time serially with my ultrasound in response to therapy, so I can track or monitor that. So we've got triage, we've got treatment, we've got monitoring or tracking, and then we've got the systematic approach where we're going to look at them systemically. So we're going to actually do sort of what you would do if you had a patient, just like you said, that patient came in, you didn't know what the problem was based on the history because it's essentially an ADR, ain't doing right, or pretty vague signs.
Yes.
They could be due to anything, right? So in that situation, what are you going to do? You're going to do a very thorough physical examination. And we do have what we call then the screening test which is essentially the systemic evaluation, where I'll say, okay, I really don't know what's going on in this patient, but I can still apply point-of-care ultrasound specifically because I'm worried there might be something in the abdomen. I put the probe on there. I do my similar thing. Do I have fluid in there? Yes or no? No, there's no free fluid in here. I can then ask the same question. It's a little bit higher skill level, but you could say, do I have free air in the abdomen? And we do train people to look for that as well. No, I don't. So then you can still do essentially what would be the equivalent of a thorough physical examination with a point-of-care ultrasound, asking all of those questions in that patient because we didn't have a specific one to go after. So it's more of a screening evaluation that we'll use, and we do a systemic evaluation of the patient. And then I'll look at the chest as well. I'll look at the lungs. I'll look at the pleural space. I'll look at the vessels. And then I'll say to the owner, okay, I can't find anything on physical examination. Your patient's got a slightly tense abdomen. I've checked with ultrasound, and I can tell you I'm not worried about anything life-threatening. I've ruled out the possibility of fluid. I've ruled out free air. The vena cava looks good. The heart looks good. The lungs look good. The pleural space looks good. We can do what other tests you might think would have been indicated that you were thinking of otherwise, for example, blood work or otherwise. But then I would also say, based on what I've looked at so far on the physical examination and the ultrasound, I feel comfortable with your patient stable. It's a little uncomfortable. Maybe we'll try him on an analgesic or whatever it is else that I found that I felt should be done. But that ultrasound then added a great deal of information to what I was looking at to make me feel comfortable that I'm not missing or overlooking anything because I didn't look. A lot of the reasons we don't find something is because we don't look, right?
Mm-hmm. So, but what you're actually you're pulling us back to actually still asking relevant questions, not just to look for what's in the abdomen, but look if there is fluid, if there's air, if there's signs of whatever you would find in the acute abdomen.
Yes, and I honestly believe that is the best way to go. And then when you've reached the limit, and that's the nice thing about point-of-care ultrasound, if you're doing specific clinical questions, not everybody is experienced with point-of-care ultrasound as the next person. But the nice thing about binary questions, you start within your skill sets and you say, well, I'm comfortable looking for fluid. I absolutely can do that. And I guarantee everybody can, but I'm not yet comfortable looking at that left atrium. That's okay. You've still answered that specific binary question within your skill set to add information to that patient. And I will go through all of those clinically relevant questions because, again, if I just put the probe on and say I didn't see anything, I may not know how to, when I'm starting ultrasound, look for the pancreas, look for the adrenals. So by asking the simple binary questions that I know I can answer, I've answered those in that specific patient. So I always ask those questions and rule those out one at a time with that specific approach, for sure.
Good. Thank you for that. So you mentioned some of your courses and your podcast and some other stuff during our time here, but can you maybe sum up where people can go to find you online and where it's the best to learn more?
Yeah, so I would say that the easiest way to reach me online is just to send me an email, and we'll make sure that we have my email address at the end of the podcast here. It's at the University of Calgary. Just fire me an email. Again, I travel quite a bit. Well, I used to travel quite a bit before COVID locked us down. Hopefully one day we'll all be out traveling again, and we'll be able to get some of the courses going locally. But if somebody has a question on where they might be able to find the education, if they send me an email, I'd be more than happy to say, one, where we're doing online courses or hands-on training. And I have a number of colleagues throughout the Europe and around the world that also I've worked with that are using similar approaches. And we're actually just creating the Veterinary Emergency Critical Care Ultrasound Society. We launched that, 4 of us founded that last year, and we had our first conference this past June where we were supposed to be in Belgium, but again, things got changed. So we went online, but we are hoping again to try and host that next June in Portugal, in Porto, as our second Veterinary Emergency Critical Care Ultrasound Society. And it's not just for emergency critical care, as we said. Any general practitioner that wants to know how to apply ultrasound and gain confidence answering specific questions can go to that. So the easiest thing to do is probably just to send me an email and say, do you know of anything in the area I'm in? Just let me know where you're emailing from. If it's in Denmark, we are planning to come back out there to do some more training. We often get over to Sweden as well to do some training in point-of-care ultrasound in Sweden with Evidensia, for example. So there's a lot of companies that I work with. So if you send me an email, there's a chance I'll know of somebody in the area you're in that will be hosting a hands-on session. Or if I'm out that way, I would definitely let you know when I'm out there. We do have some online education. We actually have one that's starting, what's the day, the 22nd? On the 24th, so in 2 days, we have one that's starting that'll be 1 hour a week for 6 weeks in a row. That is race approved for CE credit. We're starting that in the States. I think it's $79 US for all 6 hours of online. If anybody's super interested, the time zones might be a bit of an issue, but if anybody's super interested, we can share that link as well, and people can register. We'll be doing that once a week roughly for the next 6 weeks, but it's recorded as well. So if you can't attend it because of the time zone, but you want to see what we're talking about, then again, it's one that will be recorded and you'll have access to for several months to review and watch at your own leisure as well. And like I said, I think it's $79 US for the 6 sessions. So it's pretty reasonably priced that we're setting that up for. And I can share that link with anybody that's interested. Otherwise, like I said, probably the easiest, we have the podcasts on the UCVM website that you can look up. But just fire me an email. I'm always happy to have questions, especially from anybody coming back from my heritage, coming from Denmark. I would be more than happy to hear from you. I'd be more than happy to let you know what my thoughts are. If you have ultrasound clips that you're wondering about or you just have questions, by all means, please send me an email. I love to get the questions on ultrasound. I love to teach it. It's a really fun thing to do. And the odds are if there's an education event near you, I can set you up for that as well.
Well, thank you very much, Søren, for sharing all of your knowledge here, and thank you for your time.
Absolutely. It was my pleasure. Thank you for inviting me. It was a lot of fun, and hopefully we'll cross paths with a conference in the future, or next time I'm in Denmark, or if you happen to be over in Canada. By all means, give me a shout. There's some great Canadian Rocky tours out here in the mountains if you like the mountains.
Vil du gerne se billede af, hvordan det her ser ud, så kig over på hjemmesiden SIVP.dk/135. Og hvis du er derovre alligevel, når du er derovre alligevel, så kig ind i kurserne for at se, om det er noget for dig. Det er helt gratis, som sagt. Du skal bare huske at melde dig fra inden for de 4 uger, hvis ikke du ønsker at være med alligevel. Du får gratis adgang på SIVP.dk/4 uger. Jeg glæder mig til at se dig indenfor i studiegrupperne. Det var ordene for i dag. Vi høres ved igen næste gang. Hej.